So, welcome everyone to the first Vascular worldwide webinar on the topic of peripheral revascularization. My name is Tobias Malchatik and I'm the Marketing Director EMEA for Vascular. For today's meeting, participants signed up and joining from 5 different continents, so it's truly a worldwide online meeting. Our intention was to support you with valuable updates and discussions during these times of COVID-19 where people have maybe only limited access to direct information as vascular congresses and conferences are not taking place as planned. So we are extremely pleased that we were able to bring together worldwide acknowledged vascular surgeon speakers from the USA and Europe present the latest information on clinical trials and best practice for the topic of peripheral revascularization. During the presentations, you have the ability to post questions through the meeting system. After all presentations are finished, we will start the question and answer session moderated by Dr. Nicola Teresi from Florence, Italy. You see on the right side of your screen a toolbar with a Q&A button. There you can type in your questions that are visible to all participants. Other participants can click on the like button of these questions already posted when you scroll through them, and we will rank and sort the questions that will be discussed based on the amount of likes a question has received. So thank you for joining this meeting. Enjoy the talks and discussions. And now I'll hand over to Dr. Teresi for the moderation. I see we have still some more attendees to come on, but Nicola Teresi will take over for the moderation.
Thank you, Tobias. Thank you to all the attendees for joining this meeting. My role is the role of moderator, so I am very proud for that, and it's a pleasure for me to moderate this webinar, this session with the 3 excellent speakers and 3 well-known surgeons worldwide: Professor Holland from Denmark, Professor Bradbury from UK, and Professor Farber from USA. And thanks to Tobias, to Jovi De Jure, and all the Lemaitre team for the support for this interesting webinar about the open peripheral surgery. And we have 3 speeches from each speaker, 20 minutes for each speech. And then we will have a final discussion after the 3 speeches. And I think we can have 30-40 minutes for the discussion. So I invite all the attendees to pose questions, to make questions on the chat. And then Tobias can filter some questions for me, and we can discuss all together some topics after the 3 speeches. So I would like to introduce the first speaker. Is Professor Kim Holland from Denmark. He's a specialist in cardiac surgery and in vascular surgery after training in Denmark and in Australia. And he's now full professor of vascular surgery at the Southern University of Southern Denmark, and he works in Kolding. And he's a past president of the Danish Society of Vascular Surgery, and he's one of the most active surgeons in the northern part of Europe about open peripheral surgery. And I invite you to have the talk. The title of his talk is a Review, Experience and Current State of Peripheral Revascularization. Please, Professor Holland.
Thank you. Thank you very much. I am very glad to be part of this webinar. I think we should discuss what should we really do while we're waiting for the results of the BEST-CLI and the BEST-CLI studies that we'll hear about in a moment. The big question is, of course, whether we should choose bypass or balloon angioplasty as our first option for our patients. So in general, I think most of us would consider balloon angioplasty to be the safe and minimally invasive option. It may also be the cheapest option, especially if you do not use drug-eluting balloons and if you don't count the costs of re-interventions. On the other hand, bypass operations, especially when using autologous veins, is a durable alternative and with well-documented results from a couple of decades longer than those of the balloon angioplasty. There are reasons why we consider a vein bypass to be the most durable alternative. The endothelial cells of the vein have very strong antithrombotic qualities. It produces nitric oxide, interacts with a lot of other cells and platelets, and it responds to the shear stress patterns of the flowing blood. This is so highly complex a set of mechanisms that we're not likely to ever be able to mimic them with a prosthetic graft or a stent, and much less with the broken thrombogenic surface you get after a balloon angioplasty. Another reason why we consider the bypass option to be the most robust kind of revascularization is that it renders the complexity of the lesion irrelevant. It doesn't matter if the vessel is occluded or if there's in a bifurcation or if it's very long because you just bypass it. I think it's a criticism that can be made about many very experienced people who do a lot of endovascular treatments, that they tend to choose a high-risk endovascular procedure over a very simple standard bypass procedure. This is data from the PREVENT-3 trial, where they compared primary and secondary patency for long bypass grafts up to 60 centimeters long and short vein pass grafts down to less than 40 centimeters long. And as you can see, there's a small difference in primary patency, but with adequate surveillance and re-interventions, you get just as good patency for the long grafts as you get for the short grafts. I think the way many of us have handled the question is by following the task 2 guidelines, stating that if you have a task A lesion, a short stenosis or a very short solitary occlusion, you should do angioplasty. And if you have, on the other hand, a task B, a very complex lesion, perhaps including the popliteal region or the crural trifurcation, you should do a bypass. But the problem is that you don't have very strong recommendation for the vast majority of patients, which are in the gray area here in between. And anyway, these recommendations are based on very scarce evidence. And the impression I get from talking to colleagues all over the world is that there's a tendency to perform more and more endovascular procedures in increasingly complex lesions. When you look at the joint guidelines from the European Society of Vascular and Endovascular Surgery and the European Cardiology Society, there's been a slight shift in recommendations when you compare the guidelines on the left from 2011 to the most recent guidelines from 2017 on the right. Look at the lower panel concerning the treatment of infrapopliteal lesions. The earlier guidelines had a grade 2 recommendation that you should do endovascular first. And in the later guidelines, this has been changed to a grade 1 recommendation to do bypass using a great saphenous vein, together with a grade 2 recommendation that you could do endovascular therapy in very experienced centers and with very short stenosis. Interestingly, I'm not aware that any new evidence actually came out between the drafting of these two guidelines. So I assume that the change is based on more thorough reading of by the guidelines committees of the evidence that was already existing. So what is the evidence we have? I don't mean to steal Professor Bradbury's thunder, and we are very lucky to have him with us as the next speaker of this symposium, but by far the best study ever made comparing peripheral bypass to PTA is of course the original BEST-CLI trial. Between 1999 and 2004, they included 452 patients with severe limb ischemia and randomized them to either bypass or PTA. And as you can see, the survival curves tend to part after a couple of years. And for the patients who lived for more than 2 years after the procedure, there was a statistically significant survival benefit of 7.3 months, for those who were lucky enough to get the bypass first instead of the PTA first. The difference in amputation-free survival was also close to being statistically significant. And based on this finding, the investigators proposed that in patients whom you expect to live for more than 2 years after the procedure, you should go for a bypass first strategy. A bit along the same line in Scandinavia, Mauri Lepantalo attempted to do a randomized trial of using either covered stent or a PTFE bypass for SFA occlusions. This is in a way a trial of the best possible stent versus the worst possible bypass. And although we planned to include 120 patients, the study was stopped before time because an interim analysis showed significantly better results in the bypass group regarding secondary patency, even with only 44 patients enrolled in the study. I think this finding underlined to many of us in Scandinavia that a bypass is just a more robust kind of revascularization than a PTA. Moving away from the randomized trials with balanced groups, there are some publications of series of individual institutions where surgeons' preferences has decided this treatment assignment. A study from Pomposelli's clinic in Boston was a retrospective survey of a couple of hundred patients with claudication, with more or less an equal number in each treatment group, and a very thorough follow-up. As you would expect based on the task guidelines, the surgeons tended to do bypass in patients with more extended lesions, so that the patients in the bypass group, 48% of them had task C or D lesions, while this was only the case in 13 patients in the PTA group. So the patients in the bypass group had a larger disease burden, and based on this, you would expect the bypass patients to do worse than the PTA group. But when you look at the freedom from restenosis, freedom from symptoms of last follow-up, the freedom from symptom recurrence, and freedom from reintervention, you find that there's a significantly better outcome for the bypass group. What was the cost of this more robust revascularization for the patients? Well, there was no difference in survival. You shouldn't kill people when you treat their claudication. But there was a difference in length of stay. The bypass group stayed in hospital for 4 days, and the angioplasty group for a medium of 1 day. And which was more, the biggest cost for the patient was there was a wound infection rate, which was 16% in the bypass group versus 0% in the PTA group. But still, most of these infections were very mild, and it seems to be a small price to pay for a better revascularization. So the data we have is limited, and the main criticism you can do of the BEST-CLI trial is that it's now 15 years old. And those were the old stents and those were the old balloons. And at least the balloon industry claims that we get better results with the new balloons and the new stents. Unfortunately, as we shall hear later in this seminar, the two new trials are underway. And meanwhile, while we need to discuss what we should do while we're waiting for the results of these trials. There's a tendency towards endovascular first in many countries, but in my view, this trend is not backed by evidence, and as I mentioned, it's certainly not backed by the guidelines either, at least not in Europe. There's a serious historical experience that I think is important to keep in mind in this connection. 15 to 20 years ago, I was in cardiac surgery, and we did a lot of these coronary artery bypass procedures. This was based on sound evidence from several trials, and it had a proven survival benefit for patients with stable ischemic coronary disease. Then in came the new kid on the block, being percutaneous coronary intervention, or PCI. And luckily, while this was introduced, a couple of large randomized controlled trials were initiated to compare the efficacy of these two treatments. Unfortunately, during the years when we were waiting for these trials, clinicians just assumed that the percutaneous option was as good or better than the bypass. and the number of coronary bypass operations performed decreased dramatically. Not until we got the results of the trials did we realize the scale of this disaster. These are 5-year follow-ups from the Syntax trial, which randomized 1,800 patients to either bypass or PCI. If you look at the risk of suffering a myocardial infarction within 5 years after the procedure, in the bypass group it was 3.8%, and in the endovascular group it was almost 10%. And that's of course what happens when their revascularization fails. They get a myocardial infarction, we get an amputation. And this was almost 3 times as often in the balloon angioplasty group compared to the bypass group. Risk of needing a new revascularization was almost twice as high in the endovascular group, and the risk of cardiac death, which is the important, a very serious endpoint, was 9% in the PCI group, the endovascular group, compared to 5% in the bypass group. That means 4% or 36 persons of the 900 patients in the endovascular group suffered cardiac death during follow-up just because they were so unlucky to draw the endovascular first option. The other study was Freedom trial, which only included patients with diabetes, but 1,900 of them. And this study was not just cardiac death, but death from any cause that was highly significantly higher during follow-up in the endovascular group. And interestingly, if you look at this panel, all the subgroup analysis regarding complexity of the lesion, race, sex, comorbidities, there's hardly any subgroup where you can think of that benefits from endovascular compared to open surgery. But even with such very clear results, it's proven difficult to roll back that endovascular revolution in cardiac revascularization that took place while we were waiting for the results of these trials. So one argument for changing clinical practice while we're waiting for the results of the trials is that everybody has the impression that we get better results with endovascular therapy than we did 15 years ago when the BEST trial was performed. And I think this is true, but it may just be because of better antithrombotic and lipid-lowering therapy. So I was a little interested in seeing how the results of our bypass operations had changed during the same years. I looked at our own database at our clinic in Kolding and found that patients with in situ bypass operations to crural vessels performed back in the time when patients were included in the BEST trial and compared it to a later period. We performed about 450 of these procedures in each group when we excluded re-interventions and operation on the second leg of the same patient. Looking just at safety data from the index stay in hospital, the complication rate had generally diminished between the two time periods. In-hospital mortality rate had halved, although this was not statistically significant. But we also had fewer cardiac complications, and we had fewer wound complications, and we had fewer amputations and post-operative occlusions of the grafts. Looking at efficacy, I got the permission to look into the national registers to see how the patients were doing in terms of amputation-free survival, and I found the later group fared significantly better than the early group. So it seems that not only the results of the PGA, but also the results of the bypass have improved since the time of the original BEST trial. So what about the drug-eluting balloons? Are they not the ultimate game changer? The main weakness of the balloon angioplasty has always been the endothelial dysplasia caused by causing target lesion restenosis. And if you just look at the risk of needing target lesion revascularization, the paclitaxel coated balloons do prevent reinterventions. And there may even be a small advantage when looking at a composite endpoint, including reinterventions as a whole. But the Katsanos meta-analysis from last year, among other disturbing findings, showed that twice a high mortality rate at 4 to 5 years follow-up compared to plain old balloon angioplasty. The analysis has just this month been performed at an individual patient level, or at least been published this month. And though the difference is not as big, there's still a 30 to 40% increased mortality rate after paclitaxel-coated balloons. The increased mortality is divided between many different causes, and we don't know the mechanism. But the signal is certainly disturbing, and many of us have abandoned the use of paclitaxel balloons so far. So in conclusion, the evidence suggests that bypass is a more robust kind of revascularization than balloon angioplasty. BEST-CLI is the only high-quality trial published to compare the two strategies and suggests that bypass first strategy should be applied to patients expected to live for more than 2 years after the procedure, especially when the great saphenous vein is available. Results after PTA have improved after the era of BEST-CLI, but so have the results after bypass. Drug-eluting balloons do not change the game, and while we are waiting for the results of the new trials, I would say that the results from BEST-CLI are still valid, since the bypass first strategy should be applied to patients expected to live for more than 2 years after the procedure, especially when a great saphenous vein is available. Thank you.
Overview of the open peripheral revascularization, and I had a lot of questions, but the time for discussion is after the 3 speeches, so now I invite the second speaker, and it's a pleasure for me to invite for this speech Professor Bradbury, because he is one of my mates about research and about Basel trial. Everyone knows Professor Bradbury for that. And it's time of his speech, and the time of his speech, sorry, because I have lost the title of his presentation. Okay, update on the Basel II trial. But I know that Professor Bradbury in this speech will present us even the outcomes and the results of a Basel III trial. Okay, so please, Professor Bradbury.
Okay, I hope you're seeing that.
Yes.
Okay. Well, thank you, Nicola. Thank you, Nicola, for the kind introduction, and thank you to my colleagues and Tobias at Lemaitre for inviting me to come and speak at this webinar. It's a great opportunity, and I'm very grateful. So what I'm going to do is update you where we are with the Basel trials, but I'm very happy to also talk perhaps during the Q&A about what we're doing while we're waiting for these trials, if that would be of interest. So I don't have any conflicts of interest or disclosures to declare. So Kim has spoken about the Basel I trial, which I guess is familiar to everybody now. It was done a long time ago, but as Kim suggests, not much has really changed relatively between bypass and endovascular in the intervening 10 or 15 years. One thing you have to remember about Basel is it was primarily a femoropopliteal trial, so about 75% of the interventions were fem-pop. So it didn't tell us very much about the infrapopliteal segment, which of course in the intervening years has become increasingly more important with diabetes. And it doesn't tell us anything about drug technologies, because those technologies didn't exist. So we managed to get some grants from the National Institute of Health Research, which funds most of the clinical research in the UK. The total funding is around about 4 to 5 million pounds. That's about 5 million euros, almost $6 million. So Basel 2 is looking at critical ischemia with the infrapopliteal segment, and we're randomizing patients between vein bypass, BEST endovascular. About 25% of the bypass in Basel 1 were prosthetic, and they did really badly, worse than endovascular. So in this trial, we're just having a vein versus BEST endovascular. And BEST endovascular can be anything you want it to be. In the UK, it's primarily plain balloon angioplasty, with hitherto some limited use of drug balloons, although much less now than was the case a couple of years ago. Basel 3 is looking at femoropopliteal interventions. There's no surgical arm, so we're comparing plain balloon angioplasty with a bailout bare metal stent versus a drug-coated balloon with a bailout bare metal stent versus primary drug stent. The minimum follow-up in both trials is 24 months, and the primary outcome is amputation-free survival, as it was for the Basel trial. But we're looking at many other clinical endpoints, as you can imagine. And we're also very interested in the quality of revascularization, because one of the things that came out of Basel that perhaps we didn't emphasize as much as we might have done at the time is, although you might say the body and leg count wasn't particularly different between the two groups, at least not out for the first couple of years, there was quite a big difference in terms of quality of revascularization. I mean by that, healing of minor amputations, relief of breast pain. So that's something we really want to focus on with these trials. We're very interested in quality of life related to that and functional status. And as is the case with all UK NIHR trials, there's a comprehensive health economic analysis alongside the clinical analysis. So these are the latest data I can share with you with regard to Basel 2 recruitment. So as of the 20th of June 2020, we had recruited 336 patients. This trial has been extraordinarily difficult to recruit to, and it's taken us much longer than we expected to get these patients. But we were getting along reasonably well up until the COVID-19 lockdown in the UK, when essentially randomization came to a halt. Initially, we had expected to have to randomize 300 patients in each arm, giving a total sample size of 600. But because we have taken longer to recruit the patients, each patient contributes more follow-up than we had anticipated. And also the event rate, which was based upon Basel 1 outcome data, because it was the best data we had at the time, the event rate has been somewhat higher in Basel 2 than it was in Basel 1, which I think backs up Kim's point and points made by other people that in fact the outcomes from critical ischemia overall haven't hugely improved, and disappointingly haven't hugely improved over the last 10 or 15 years, at least not within the UK. So we have 336 patients against a revised sample size of 389. Now, we've agreed with the funders to make this a time to event analysis, so we'll keep going until we have enough patients to be able to have 247 endpoints. So that's major limb amputation, that's above ankle amputation, or death from any cause, whichever occurs first. That's amputation-free survival. So we have 86% of the revised sample size patients so far, and we've observed just over 50% of the events, and we require another 53 patients. In fact, our colleagues in Stockholm randomized 2 patients the other day, so in fact we've got 338 patients now, and we need 51 patients. Looking at the funding envelope, we expected to end recruitment in November 2020, so just in a few months' time, but that was based on a pre-COVID planning. So we'll have to see where we go with that and how generous the funding agency are in allowing us to recruit for longer. As I said, we're planning a minimum 2-year follow-up, and it is possible the sample size will fall further from 389, will end up being less, because we suspect that quite a lot of endpoints have not been reported, especially during the lockdown period. So this is likely to change again. Just to show you recruitment by centres, we have Hull Royal Infirmary, Professor Ian Chetter's group out in the front. We have our colleagues from Stockholm, and then we have Guy's and Thomas's in London, and then a collection of Midlands hospitals, which is where I work. And I'm also grateful to Kim and his colleagues in Kolding for randomizing patients into this trial as well. So I can show you the outcome for the cohort as a whole. Obviously, I can't show you the outcome by randomized group, and of course, I've never seen this. Only the Data Monitoring Committee see the data by allocated treatment. But if you look at people who have no amputation-free survival, so that's people who have lost their leg and or died, that accounts for 39% of the cohort so far. We have 29% of the patients are dead, and 15% of the patients have amputations, some of whom have subsequently gone on to die. If we look at the deaths, then CLTI 16, cardiac deaths, cardiac failure, myocardial infarction, sudden cardiac death 35, and cancer 10. If we look at the level of amputation, it's roughly 2 to 1 below knee, above knee. So as I said, the sample size is based upon reaching 247 primary outcomes, and as I say, we're about 86% of the way there to that revised recruitment target of 389 patients. So this again is the whole cohort, 336 patients as of 20 June. And you can see that, as expected, the patients do quite badly. The median follow-up is around 44 months, and the estimated amputation-free survival at 3 years is 53%, with 65 patients at risk at that time. But as I've said before, the outcome is probably worse than that because we suspect that not all deaths and amputations have been reported yet. There's always a lag phase to that, especially during the COVID lockdown period, which has made following up patients more difficult. And again, if we look at overall survival for the whole Basel II cohort, again, same follow-up, obviously around 44 months. The estimated overall survival at 3 years is 62%, with 70 at risk. And these figures are extremely similar, in fact, to Basel I, again suggesting that not a huge amount has changed in terms of the overall success of revascularization in these patients since Basel I. So that's a brief summary of Basel II. So Basel III, if you remember, this is 3 endovascular options for fem-pop disease with no surgical arm. Everything was going rather well until November of last year, when this meta-analysis that Kim has spoken about was published. And although the great majority of the patients in this meta-analysis were claudicant patients and not critical ischemia, in discussion with all stakeholders, the sponsor and the funder, we felt that we had no option but to pause the trial at that stage. And at that stage, we'd randomized 411 out of estimated sample size of 861 patients. So we were just short of halfway there. To cut a very long story short, there was lots of discussion about what we should do with drug stents and balloons. And our regulatory authority, which is our sort of equivalent of the FDA, the MHRA, put together an expert group. I was not part of that because obviously I was conflicted being the chief investigator of the Basel III trial. But what they came up with in June 2019 was helpful to us. Essentially, in the UK, we have stopped using drug balloons and stents in patients with claudication, but they did support the use of these technologies within trials, and they actively encouraged Basel III to restart. And the other recommendation is that we should follow the patients up for 5 years, not 2 years as originally planned. So we had to restart the trial, which was almost like starting all over again, actually. And as with Basel II, because it had taken us longer to recruit the patients, and because the event rate was somewhat higher than we had expected. The sample size came down from 861 to 477, maintaining 90% power with a primary analysis based at 24 months. So again, like Basel 2, it's a time to event analysis. We need 291 primary endpoints. So where are we? Well, this is the recruitment graph for Basel 3 right from the beginning in January 2016. You can see there's a big blank area in the middle, which was the pause of around 10, 11 months because of the pause after the Katsanas publication. But actually, we were beginning to recruit relatively well until the COVID lockdown, when essentially recruitment, as with Basel 2, has stopped. So at the moment, as of the end of June, we have 444 patients recruited against a revised sample size target of 477. So we are 93% of the way there, and we need another 33 patients. Again, this is just recruitment by center, and I'm pleased to say that my own hospital at the bottom is the lead recruiter for this trial, and we're very much hoping that now things are getting a little bit easier with COVID, we can start recruiting patients again. So again, I can show you the overall cohort data for Basel 3. Again, obviously, I can't show you by allocated group. So the no amputation-free survival in this group is 33%. We've had 124 deaths, which is 28%. Again, the causes of death really very similar to what we saw in Basel 2. We had 37 major amputations with a rather more balanced between above knee and below knee. So we randomized 93% of the patients that we need to recruit, and we've observed so far 51% of the primary outcomes. This is amputation-free survival for Basel 3 at the end of June, based on 444 patients. And you can see the estimated 3-year amputation-free survival is 51%, which is almost identical to Basel 2, and in fact is almost identical to Basel 1, except that whereas in Basel 2 the mean follow-up was 44 months, it's only 34 months. So overall, the patients in this trial are doing somewhat worse so far than the patients in Basel 2. And again, these are the data for Basel 3 to the end of June, with overall survival based on 444 patients. And again, in terms of overall survival, they're actually doing considerably worse than Basel 2, and actually quite a lot worse than Basel 1, despite the relatively short follow-up and the low numbers of patients at risk at 3 years. So if we compare Basel 2 and Basel 3 at the end of June, we're 86% of the way there with Basel 2. We're 93% of the way there with Basel 3. We've roughly seen half of the endpoints we need to see in both trials. The follow-up is about 10 months longer in Basel 2 because it's running longer, but the amputation-free survival rate is about a third in both trials. So there's not a big difference between the two trials in terms of the overall outcome. What's going to happen next? I think we're relatively confident that we should be able to recruit to Basel 3 by November, or at least by the end of the year. And we're relatively confident that the funding authority, because of the huge interest around drug balloons and stents, we're relatively confident that the funding agency will feel able to fund that. So I think we will get to target recruitment on Basel 3. Unfortunately, I think with Basel 2, it's unlikely that since COVID, there's been a massive swerve away from doing bypass surgery. A lot of people are having primary amputations, and the people undergoing revascularization in the UK are largely having endovascular. So I think it's probably unlikely that we will get to the target recruitment of 389 by the time the funding authority probably calls time on the trial, which I think will be towards the end of this year. So I hope that's useful. I'll stop there, and of course we'd be very happy to take questions on this or any other aspect of CLTI management with a question and answer session. Thank you very much.
Thank you, Professor Bradbury. Even for you, I have a lot of questions, but it's not time for questions now. But I invite again all the attendees to put questions on the screen bar on the right side of the screen. I have seen that some questions just arrived, 2-3 questions, but I invite all the attendees to make other questions because we will have time to discuss them. And now we go on with the third and last speaker of this webinar, Professor Farber. I'm very proud to introduce you, Professor Farber, because he moderated me on the last VIT symposium in New York during my presentation of our Italian registry about in situ saphenous bypass, the limb-safe registry. And so I'm very proud to introduce Professor Farber. He's the Chief of Division of Vascular and Endovascular Surgery at Boston Medical Center and is Professor of Surgery and Radiology at Boston University School of Medicine. And Professor Farber is a co-chair of the BEST-CLI trial. I have the honor to participate in this trial with my center, together my colleagues in Florence, in Italy, at San Giovanni di Dio Hospital in Florence. And so I am very proud again to introduce him, Professor Farber, to make a speech, an update about the BEST-CLI trial. Please, Professor Farber.
Webinar, and I'm honored to be participating in it with my colleagues. So I want to talk to you about the BEST-CLI trial, give you an update, and also tell you about how we manage our patients with chronic limb-threatening ischemia, or CLI, while the data is still in. These are my disclosures. So I think that everybody on the webinar probably understands the scope of peripheral arterial disease and the fact that it affects many people, and chronic limb-threatening ischemia in some instances is described to affect up to 10% of patients with PAD, with a very significant economic burden. And it's been a growing problem given the aging of the population and the epidemic of both obesity, metabolic syndrome, and diabetes. So to no surprise, this is sort of hard data showing a significant worldwide increase in prevalence in peripheral arterial disease, and this is expected to increase. Of course, the goals of treatment are medical therapy to optimize cardiovascular risk, limb-related soft tissue therapy, and revascularization. And revascularization is performed to relieve pain, to heal wounds, preserve a functional limb, avoid major amputation, and maintain an ambulatory status among those patients who can walk. And there are two revascularization strategies. There's open vascular surgery and there's endovascular therapy. Open vascular surgery, of course, includes inflow bypass, endarterectomy, but the workhorse for CLTI, CLI, is really infrarenal bypass. And of course, surgical bypass and endovascular therapy have their advantages and disadvantages. You can see those in white and in green. Just to focus that, when you really focus down, surgical bypass promises durability, but is more invasive, while endovascular therapy is minimally invasive, but promises or has less durability. At least that is the sense. At the end of the day, though, we do need to figure out how to treat this particular patient, a patient that doubtlessly many people on this webinar have seen before, a woman with diabetes and right forefoot gangrene, normal femoral but no distal pulses, low ABI, and present single segment saphenous vein. This might be her angiogram, and the question is, with this angiogram, what is the best way to manage this patient? What is the best first revascularization, because these patients may have many revascularizations. But what is the first revascularization for this patient particularly? I'll tell you that we presented this case to more than 600 separate vascular specialists, and we get a response anything from endovascular, it's a no-brainer, to absolutely bypass. So there's a lot of equipoise. And so this really begs the question about how do you revascularize any given patient with CLI who is a candidate for both types of strategies? The reality is there's a data desert out there. Now, of course, you might argue that there's a lot of data, and there is a lot of data, but I will argue that a lot of this data is limited. It's retrospective, often poorly controlled. The endpoints that are used are often suboptimal. There's bias. Often claudicants are lumped in together with patients with CLI, and the follow-up leaves much to be desired. Is there any level 1 evidence? Well, of course there is. Dr. Holland has referred to this, and of course we have Dr. Bradbury that you've just heard from. Basel trial is the only trial out there, randomized trial, to compare the strategies, and has provided valuable information for us. But there's a huge evidence gap. Take a look at the coronary artery disease, cerebrovascular disease, and then CLI on the right, and look at the completed landmark randomized controlled trials. How many are there on CAD and cerebrovascular disease? And then there's this one orphan trial, basal trial. And another way to look at this is more than 100,000 patients studied in the coronary artery space, and only 452 studied in CLI. And of course, this supports the fact that there's a significant evidence gap in this field, and this is part of the reason why we're having this webinar. And to no surprise that a recent meta-analysis comparing strategies concluded that there is not enough high-quality data available to guide clinical decision-making. And this is exactly why we're running the BEST-CLI trial, and this is why Dr. Bradbury is writing Basel 2. So BEST-CLI is a prospective, randomized, multi-center, multi-specialty, pragmatic, open-label superiority trial. It is funded by the NIH at the level of $27 million. The goal of the trial was to assess treatment efficacy, functional outcomes, cost, and really value in patients with CLI who had infrainguinal PAD, who were candidates for both open vascular surgery and endovascular therapy. The trial aimed to enroll 2,100 patients. And the idea was to separate those patients into two cohorts. Cohort 1 were patients with single segment saphenous vein that was adequate to use, basically best possible candidate for bypass. Those patients were in cohort 1. Cohort 2 were patients who did not have single segment saphenous vein. So if they were randomized to open surgery, any conduit could be used, including prosthetic. Those groups were then stratified by presentation, whether the patient had ischemic rest pain alone or tissue loss, and stratified by anatomy, whether or not the patient had tibial disease. And then once the patients were stratified into those buckets, they were randomized into either best endovascular therapy or best pragmatic therapy, surgical therapy. So basically, we allowed the operators to decide the techniques they wanted to use. So if a surgeon wanted the patient randomized to open surgery and the surgeon wanted to do the bypass in situ, that would be absolutely fine. If they wanted to do it reversed, that would be fine. Endpoint to evaluate treatment strategies. Major adverse limb event-free survival includes death, includes major amputation, but it also includes major interventions. And then we have a number of secondary endpoints. We have a robust cost-effectiveness analysis that is going to look at all financial costs of care, functional status, and quality of life. And BEST-CLI promises to answer many, many questions. There are many questions it will not answer, But the penultimate question that it's going to answer, and this is the reason we organized Matt Menard and I, and Kenny Rosenfield. This is the reason why the PIs organized a trial. Basically, to see how infernual bypass with optimal conduit fares against endovascular therapy. In other words, if a patient comes to your office and they have good single-segment saphenous vein, and that can be done using surgical techniques or endovascular techniques, what is the best way to treat them? Is it really endovascular first, or is it surgery first? That is the penultimate question that we're going to answer. BEST-CLI is positioned to provide a treasure trove of relevant data about CLI and its management. It will define, together with Basel II, an evidence-based standard of care that currently does not exist in this space. So we have activated 170 sites during the course of this trial. As of last, we had 134 sites that were operational, 115 in the United States, 14 in Canada, 3 in New Zealand, and then 1 in Finland and 1 in Italy. 3/4 of our sites were multidisciplinary. As many of you know, there's a lot of specialists that treat patients with CLI, vascular surgeons, interventional cardiologists, interventional radiologists, vascular medicine specialists. These types of specialties vary from country to country. Certainly in the United States, all of these treat patients, and we've made a big effort to include everybody in our trial. In terms of investigators, we have almost 1,000 investigators participating in the trial. The majority are vascular surgeons because the reality is that it is the vascular surgeons who do a majority of patients with CLI. But we do have interventional cardiologists, interventional radiologists, and vascular medicine specialists participating and contributing to BEST-CLI. I cannot share with you the exact numbers of baseline characteristics. We have those available. They're going to be presented shortly, but I cannot share them. But I'll tell you that we have less women than predicted, but we have similar amounts of patients who are of non-white race and who are Hispanic than predicted. And when you look at the characteristics of this patient cohort, it is very similar to what you would expect to see in a cohort of patients with CLI, and that is wonderful for us. A few updates. We have a companion CLI registry that's been funded by the NIH that is led by Manesh Patel and Shrik Vermapuli from Duke that aims to enroll 1,200 patients at 40 BEST-CLI sites. And the purpose of this is to get a sort of a context for the BEST trial. Originally, the plan was to have the registry and the trial run together. Unfortunately, that wasn't possible, but they are actually onboarding sites right now. We have 10 activated sites in the registry, 43 participants enrolled. Now BEST has completed its 5th year of enrollment and has reached the end of its granted funds. So we have to kind of evaluate excuse me for a second. We do have a mandate to provide answers to the questions that are posed, and we need to do that with appropriate statistical certainty or power. Of course, power depends on a number of factors, including the sample size, the magnitude of effect, length of follow-up. The acceptable degree of power is 80%, but we want it to be as high as possible. And the good news is our aggregate event rate is higher than predicted, just like what Dr. Bradbury said. It's higher than predicted, but the bad news, we realized that the power needed to be optimized, and that meant either a larger sample size or longer follow-up. And so more funds were required for either of these. And so this is sort of the position we found ourselves in. We're the mouse here, and the cheese is right there, but there's a mouse catcher there. So our funding body has told us that they could not provide us any more funds, which was an unfortunate event, given that they initially promised to do so. And so we went out and raised $3.3 million to date, and we're trying to raise $4 million more to be able to finish the trial and have the trial have adequate power to answer the questions that we originally posed. This is the list of donors to date. We're incredibly grateful for the fact that the majority of vascular societies in North America has contributed, as have industry and others. And there are other folks that we're approaching right now. There are difficult decisions that we had to make. We had to stop enrollment to the trial, and we did that on October 20th, 2019, with 1,843 subjects randomized. So we were 88% complete. The reason we stopped enrollment is because enrollment is much more expensive than follow-up. We also stopped follow-up in cohort 2. These are patients with who do not have adequate single-segment saphenous vein. That was a much smaller cohort, and so that cohort stopped with 397 enrolled and 83% complete in December 31st, 2019. The follow-up of cohort 1, which is the critical cohort, patients who have single-segment saphenous vein, is continuing. And right now we have enough funds to continue enrollment until the end of December 2020. That means 14 months of follow-up up to the last patient in. And that will get us around 85% power. But we are not giving up. We actually want to achieve a 24-month follow-up for cohort 1, meaning that basically the trial would end on October 2021, and that would give us almost 90% power. And so we are doing everything possible to raise funds to get us to this important milestone. This is where we are right now. We can see the summit. We're not quite there, and maybe some of the hardest parts of the travel are still ahead, but we can see the end of it. And of course, I'm not going to say much about Basel 2 and Basel 3. You just heard about it. But these trials are going to significantly complement BEST-CLI, or BEST-CLI will complement these trials. I'd like to finish talking a little bit about how one decides between bypass and endovascular therapy in clinical practice before all of this level 1 evidence becomes available. At the end of the day, we are treating patients right now. And I just want to say that I think it's important to consider 3 domains as it relates to these patients. So the patient-centric domain, the limb domain, and then the anatomy domain. And there's a lot of intersection between these. When I'm talking about the patient domain, these are patient factors: ambulatory status, frailty, comorbidities, estimated life expectancy, prior vascular interventions. These are domains that, or aspects that actually weigh on our decision of how to, what sort of strategy to offer to the patient. There are limb factors. Everybody here probably understands that there's a difference between the likelihood of limb salvage between these 3 patients. And that is an important factor in deciding how to choose intervention. And then there's relevant anatomic factors: extent of occlusive disease, location of disease, lesion length, size of treated artery, degree of calcification, quality of runoff, quality of target, and whether or not there is single-segment saphenous vein or very well any vein available. And so I'd like to share with you my personal sort of generalized CLI treatment strategy. At the end of the day, everybody's strategies are different, and this is part of the reason why we're doing these trials, to infuse evidence base into our decision making. But this is sort of how I think about the patients before level 1 evidence is available. So these are the scenarios where I favor bypass. Patients who are ambulating, patients who have few comorbidities, longer life expectancy, patients who have failed a previous endovascular intervention, those patients I would favor bypass in. If there's a situation where you need really good sustained blood flow to heal a heel ulcer or an extensive wound, or perhaps somebody has ischemic rest pain and you want to intervene on them in a way that is long-lasting, because once the intervention fails for ischemic rest pain, typically the rest pain resumes. So these are scenarios that I also consider bypassing. Patients who have multi-level diffuse occlusive disease, and certainly when there's adequate single-segment saphenous vein available, those are, again, scenarios where bypass is favored. Scenarios where I favor endo are patients who are frail, those who are high surgical risk, who have shorter life expectancy, who may have failed prior bypass, patients who have small wounds, patients who have discrete focal occlusive disease, patients who have very large legs or have a prohibitive groin, or perhaps have no vein. Those are patients where, in my opinion, endovascular should be favored. And of course, there's a patient population where amputation is the right thing to do. Patients who have poor functional status, multiple comorbidities, non-ambulation, short life expectancy, extensive tissue loss. So in conclusion, there is absence of good data to guide treatment of CLI. BEST-CLI and basal trials will provide a treasure trove of invaluable data on CLI and its management. Patient, limb, and anatomical factors are used today to decide on CLI therapy in the current, what I call, data void. At the end of the day, open surgical bypass and endovascular therapy are not exclusionary therapies. They're complementary modalities. And I think that it behooves us to learn to do both really well. And I just want to finish with a quote from Robert Linton, who's one of the fathers of vascular surgery from Mass General Hospital, a place that I trained. And he used to say that you got to do the right thing and you got to do it right. Thank you.
Thank you, Professor Farber, for this wonderful presentation. And I really enjoyed your final slides with your personal approach to CLI treatment. So now it's time for discussion. We are on time. It's 4:05 in Italy. So we have, I think, about 30 minutes for the questions, and we just received 4 questions from the audience. I think that 2 questions are very similar, and I can collect them with just 1 question. And the question is, who makes the decision for the patient for the treatment? Is the treatment decision open versus endo driven by healthcare system or about the opinion of the surgeon? And okay, I think that every speaker can answer to this question. So a quick round from all the speakers just to have an answer from Denmark, UK, and USA to this question. Please, Professor Hulin, you are the first.
Okay, thank you. Well, I think there are 2 questions: what's driving it, and who's making the decisions. At least in my clinic, we're making the decisions in a multidisciplinary team with people who have strong endovascular competencies and people who are good at open surgery. I think that's mainly it's the vascular surgeon who has seen the patient and who knows the patient more than the interventional radiologist who calls the shots. But I think we have to one thing we have to realize when we compare to the situation with coronary artery disease, where everything went endovascular while we didn't have the evidence to base it, is that we are not in that situation because normally we have this patient ourselves, so we can make the decisions ourselves. We're not dependent on some other specialty to send us the patients. And what's driving it is, I think it's very different from country to country. In our systems in Scandinavia, which is tax-based systems, and we don't have to think so much about the economy. I think it's mainly driven by the clinicians and not by the system. I think in other systems it may be more driven by reimbursement and so forth.
Okay, thank you, Professor Bradbury.
So I think my answer is quite similar to Kim's. In the UK, essentially peripheral arterial disease is looked after by vascular surgeons who are now separate from general surgery. Some interventional radiologists are involved, but increasingly the vascular surgeons, the younger ones certainly, are doing their own endovascular interventions, and interventional cardiologists don't play any role in peripheral arterial disease in the UK. So in terms of the decision making, it's a multidisciplinary group of vascular surgeons and with interventional radiology in some units still. I think our healthcare system is a tax-based. It's a national health service. So the economics per se and reimbursement are not important, but we are very short of resources. And I think it's, all things being equal, it's much easier to take a person to the interventional suite and do an endovascular procedure than it is to get someone into the operating theatre for 3 or 4 hours and then in a bed for 4 or 5 days before they can go home. And I think that's been one of the reasons that it's been so difficult to randomize patients in Basel II. A lot of my colleagues say that they have intellectual equipoise, but logistically, when it comes to looking after a person with limited resources, they often feel forced down the endovascular route rather than considering bypass. And of course, the other thing is the patients and their families often have quite strong views about what they want. So that's roughly how it works in the UK.
Okay.
So in the United States, we have a number of specialists, as I intimated, who perform procedures on patients with CLI. And in fact, we published a paper last year in Journal of Vascular Surgery, first authored by Rick Powell, where we compared the percentages of specialties treating CLI in the Medicare database to who is doing it best, and it's very similar. So the pie chart that I showed, where vascular surgeons are, there's 65% of patients of investigators are vascular surgeons, is very similar to what's present on the ground in the United States. But having said that, we do have radiologists and cardiologists that take excellent care of some of these patients. In terms of what drives the treatment decision, I'll tell you what does not drive it. So evidence or data does not drive this decision. Science does not drive the decision about how to best treat our patients, which is actually pretty scary to admit, but that's just the reality of it. Decisions are made by all sorts of things. Finances drive it. If I was a vascular surgeon and I had an outpatient vascular lab, I would certainly be more incentivized to do endovascular procedures in my lab rather than take those same patients to the operating room, to the hospital. And so bias. A lot of physicians are not comfortable doing bypass surgery anymore, and those physicians are certainly not going to do it. They're going to try endovascular, even though in some situations bypass would work best. There's a lot of chaos, and the hope is that the basal trials and BEST are going to infuse some evidence base, and then we can, once that happens, hopefully we're not as far out as the cardiac surgeons are in the treatment of CABG. Maybe we can come back and re-equilibrate and do the right thing for our patients.
Okay, Professor Faber, thank you. Just a short comment from my side. In Italy, we are quite lucky because we vascular surgeons are able in 90% of the centers to perform both procedures, open and endo, so we can decide for each patient the best option for, and we can make a tailored approach to our CLI patient. Okay, there is another question. I really appreciated it because all of you are professors of vascular surgery in Denmark, UK, and USA. And the question is about the training of young vascular surgeons about open surgery. What do you think about that? Professor Hulin, you are always the first.
Thank you. That gives me the possibility to say the obvious things, and the other two need to find out something really clever to say. But I think that I think we have a problem at the moment that we are training perhaps a little more young surgeons than we have patients for. And I think we have to be very careful every time we make a case to look into whether is there a part of this procedure that the younger colleague can do so that they get enough hands-on training. Also, in the Danish Society of Vascular Surgery, we are working on training in simulators and phantoms and stuff. I think it's when I learned to do coronary bypass, we had a box with some old veins in, and we had to do 50 anastomosis on them before we were allowed to do one on the patient. And I think that's quite a good way to think of it, that we shouldn't really be training on the patients more than necessary. I think that's the way to get around it. But of course, if you end up doing 90% endovascular, there will be only very, very little training possibility for the younger surgeons.
Professor Bradbury?
Again, a very similar answer to Kim's. I think not just with legs, but also aortic aneurysms. The last 10 or 15 years, there's been a huge push towards encouraging people to do endovascular treatments. And there is a concern, and I'm probably sounding very middle-aged here, but there is a concern that people 20, 25 years younger than me who are starting out as consultants and attendings, they don't train in general surgery, for example. So opening and closing an abdomen for them is quite a big deal, whereas they're very facile when it comes to putting guide wires up arteries. So I do think that we have gone a long way down the endovascular route, and I'm not completely sure that whatever the trials show in the UK, the Basel trial or Basel 2, I am not completely convinced that it would change practice, because we're up against, as Alex says, practice is not primarily driven by the science, because we don't have a lot of science. It's driven by lots of other factors. So we'll have to wait and see.
I think we have a big problem with training our trainees because of this endovascular issue and the fact that it's all about balance. We need balance, just like in my last conclusion slide. Endovascular is wonderful, and it's important for us to know how to do that. But open surgery it still plays a role, and until the science is there, we need to you have both skills available to us. And the problem is that, at least in the United States, there are a lot of fellowships that are heavily endo-focused. And the reason they're endo-focused is because the surgeons who are part of the fellowship have decided to become endo-focused for whatever reason. And there are many of those reasons. You can spend an hour talking about them. And they're doing a disservice at those sites. They're doing a disservice to their trainees, because the trainees need to be exposed to everything. And so it's an issue. It's a big issue with aneurysms. I agree with Andrew. And so like at our fellowship, we do everything possible to maintain that balance and do open surgery. And we don't feel that we're being somehow unethical at all, because at the end of the day, there's not a lot of science to support what we do. And so I think it's important for folks who are participating in training of vascular surgeons to remember that both endo and open surgery are important. And it's up to them to ensure balance. And right now, when every time fellows look, we have interviewing fellows once a year, and the biggest thing on their mind is how much open surgery is done, because they know this. They're looking for fellowships where there's still doing open surgery.
Okay. In Italy, the situation is similar. Just a short comment, even from my side. And from 2014, together with other colleagues, we created a school of vascular surgical anatomy, and we started with a program of cadaver labs, and they are very, very interesting, and a lot of young trainees, young vascular surgeons attended these cadaver labs in Italy. So it's an option now for the training of vascular surgeons for open peripheral surgery. Okay, we can go on from, there are other 3 questions. One, I think is a direct question for Professor Bradbury. And the question is, how quickly do you hope results of the 2 trials, so the Basel trials, will change society guidelines? What do you think about that?
So I think we will probably conclude randomization to Basel 2 and Basel 3 towards the end of this year. I don't know exactly when, because it depends on COVID and funding, and everything's a bit chaotic at the moment, to be honest, with non-COVID research. But we will then have a minimum of 2 years follow-up. So, and then it will take us 3-4 months to write up to analysis and then publish. So I think we're probably looking 2 to 3 years, well, nearer 3 years from now before we get the final results. And one of the problems with these randomized controlled trials is they just take too long. And I'm sure Alec will and Matt for BEST-CLI and Kenny wrote, you know, it's taken longer than we expected it to, because it is very difficult to get people to randomize patients. But that's when we will probably be able to share the data with people, the final results.
So you think that we must wait about 3-4 years to have a change in guideline statements, or less than 3-5 years?
Well, there's two things. First of all, there's publishing the results of randomized controlled trials, and then there's changing practice. And again, if I could use the example of open versus endovascular aneurysm repair, you know, we've had good quality data from randomized controlled trials for a long time, but it hasn't changed practice. In fact, almost the opposite is true. So the problem is, as we've discussed, you know, this is not necessarily all about the science. There are many other factors that determine how patients are treated. And unfortunately, quite a lot of randomized trials get pretty much ignored if the results aren't to the liking of the vascular community, if I can put it that way.
And about BEST-CLI trial, Professor Faber, what do you think? Could it change guidelines in the next future or not?
So if we do not get further funding, then the follow-up will end in December, and the results are going to be available probably 6 months later. So next summer we will have results. Now, what effect it's going to have on guidelines is unclear, because we don't know what we're going to find yet. We have our assumptions, but we don't know. And I agree that, you know, implementation of findings is complicated. There are many factors as to how individual physicians adopt findings of trials.
And there is a question for you. If BEST-CLI demonstrated superiority for open surgery, do you expect, will this deter interventional cardiologists and interventional radiologists to perform endovascular first approach or not?
Yeah, I don't think the issue is as much the interventional radiologist or cardiologist. I think the issue is the vascular surgery community, because it is the vascular surgery community that have jumped into the endovascular pool. I mean, at the end of the day, it's all about balance. And, you know, I think that if we find superiority to open vascular surgery, I think we are going to try to do our best for the vascular community to adopt that, and that might mean teaching people how to do bypass again. But I'm more concerned about the vascular surgeons. Obviously, the people who are adopting, as was mentioned before, adopting results of trials is tricky at best. And there are some people who, if they only do endovascular, they might continue doing endovascular. The question is, what is the best thing to do when both modalities are available to the same investigator? And so the hope is that we're going to change practice, but again, that may be a pipe dream. It may be my fantasy, but the dream is to change practice as to what and make it be based on evidence, whatever we find.
Professor Hulin, yes, I have seen your hand up.
That's fine, great. Yeah, just a short comment. I think the question is maybe not so much how soon can we change the guidelines if open surgery turns out to be better, because at the moment, as I showed in my presentation, in the current European guidelines, infrapopliteal lesions should be treated primarily with open surgery and not with endovascular. So it's already in the guidelines based on the BEST-CLI trial. So I think what may have an impact is that we have these discussions in fora between vascular surgeons, and we talk to each other about what is the evidence, what's the strength and the limitations of the evidence, and why do we do what we do.
Okay, now I have two provocative questions for the speakers. The first one is, when you have no vein available, what's your approach? And the second question is, when you decide to perform a major amputation, okay, Professor Farber showed us his indication for primary amputation on non-ambulatory patients, life expectancy less than 1 year, etc., etc., etc. When you decided for a primary amputation, who performs the major amputation in your hospitals? First, to answer to these questions, Professor Farber, we change the clockwise of the round.
So our service performs all amputations in our hospital. The vascular surgeons perform all major amputations. The minor amputations are performed by podiatrists.
So major amputations, vascular surgeons.
We perform all major amputations.
Okay.
And the first question, can you repeat that, please?
When you have no grid-saphenous vein available, what's your approach? Prosthetic graft, nothing, medical therapy, endo?
So I think it all depends on what the scenario is. If there's no vein available, I would be much more biased towards endovascular therapy.
Okay.
I mean, that's sort of the reality of it all. Now, if you have a situation where it's very diffuse disease, and it's a small wound, have I done a cryopreserved vein bypass, tibial bypass in that setting? I have. So it's a complex question, but my bias is towards endovascular.
Professor Bradbury?
Well, my answer is really the same as Alex, and he put his slide up about his decision making, and I would agree with that. There was nothing that Alex said about his own personal approach to the condition that I would disagree with. I mean, in Basel 1, 25% of the bypasses were prosthetic, and it's like a lot of things in life. If you were to do it a second time, you might do it differently. And if I was doing it again, I would not have allowed prosthetic bypasses in, because I think it muddied the water. But I think they did really badly. And hypothetically, if we had done the Basel 1 trial, but only with vein, I think my hunch is the advantage for vein would have been much stronger, for a bypass, would have been much stronger than it was. So for all intents and purposes, people have stopped doing prosthetic bypasses in the UK for critical ischemia. There might be a very small number of cases done, but basically it has stopped. And I haven't done one for years and years and years.
And about amputation, major amputation,
sorry. So they're all done by, I mean, very, very, for non-vascular amputations, tumor and things like that, done by the orthopedic surgeons, but all of the dysvascular amputations are done by vascular surgeons. Yeah.
Vascular surgeons. Professor Hulind, you had more time than before.
Yeah, on the other hand, so Alec and Andrew said all the clever stuff, but I think that for one thing, I wouldn't say the patient had no vein available just because there wasn't a great saphenous vein available. Sometimes you can find veins somewhere else. I'm not. I would sometimes use a prosthetic graft, usually a PTFE heparin coated with a vein cuff, especially if the alternative would be to find 4 or 5 different pieces of vein and stitch them together, because I think when you look at the results from the PREVENT 3 trial of these multiple veins put together and compare them to, for instance, the Propatin trial, which we were part of, I think there's not much of a gain in a lot of small pieces of vein compared to a prosthetic graft, and I think there may be a small advantage with using the vein cuff for the prosthetic graft. But also, like Alec and Andrew, I would be biased more towards endovascular if there's not a great saphenous vein available. Yeah.
And we just received a question about alternative grafts to vein, and the question is: are biological grafts a better alternative to artificial grafts? What do you think, Professor Hulin?
Okay, well, we are experimenting a little with the OmniFlow graft, which is a kind of a biological graft with a prosthetic skeleton, and we use it mainly in cases where we think there's a high risk of infection, because it's in other ways a bit more difficult to handle than a PTFE.
Okay, Professor Bradbury, what do you think about biological grafts?
I must confess, I really don't have any meaningful experience with them. I've used them a few times in infected aortas, but I have to say my experience in the leg is negligible. And as far as I know, they're not really being used much in the UK, other than in infected aortas. I think they are used, but not in the leg as far as I'm aware.
Professor Faber.
We about 10 years ago published the largest series of cryopreserved saphenous vein bypass grafts, because at the time we used them a lot, and we found a 18% primary patency rate at 2 years. So very low primary patency rate, but the limb salvage was actually quite high in these patients. These are mostly CLI patients. And so there are scenarios where I still perform cryopreserved saphenous vein bypass. And those are scenarios where there's no vein, and endovascular is either failed or not possible. And the wound is small. I don't do it for rest pain, but for small wounds, sometimes you can achieve wound healing with a cryopreserved saphenous vein bypass, and it's a very small operation.
Okay. About wounds, but not foot wounds, but about wounds complication. I have seen in the presentation of Professor Hulind a reduction of wound complication from 30% to 19% over the years. What's your explanation about that? What do you think about that? Why did you have a great reduction of wound complication during the years?
I think it's a number of things. We've been looking at the 30% is of course an outrage and should never have been up there. To my defense, I'd say that this is all kinds of wound complications, including not just infections, but also oozing for more than 48 hours and a hematoma. And I think we had at the department some more focus on meticulous surgical techniques for doing that. Also, we found, and that's even statistically significant, that there's actually fewer wound complications if we do regional anesthesia rather than general anesthesia. I'm not sure I can explain why that is. It may have something to do with the local perfusion pressure being lower with general anesthesia. But we've been able to demonstrate that there's a difference in wound complication rate with that. Also, of course, with the general complications rate with the cardiac and cerebral complications. So that's probably another thing. We stopped using clamps. I'm not sure that made much of a difference, but we got down to 13% for the last few years. So it's coming down, but it's really that it started from a too high level, I think.
Okay, I think we have the time for other two short questions from the audience. One is a philosophical question. Will endo repair become the new subspecialty for vascular surgeons? My answer is no. What's your answer, Professor Farber?
So I think that this question speaks to the fact that there are very few people who are incredibly skilled in both bypass and advanced endo. That's just the reality. But I think most people, there are many people who do both easily well, but I think that I don't think it's going to be a separate specialty at all. I think that in any group, there's going to be one individual who might be the most skilled in the group for doing advanced endo, and there'll be an individual who might be a little more skilled in doing aortic surgery, and another individual who is more skilled doing bypass surgery, and that's how the groups are. That's how it's playing out right now in many groups, at least in the United States, and I think it's going to continue that. I don't think endovascular is going to be a separate specialty. It's part of what vascular surgeons do.
Professor Bradbury, always in the middle.
Well, I agree. In our system, it's quite usual for two consultants or attendings to operate together, which I suppose is a luxury that is not possible in some other healthcare systems. But we're salaried, so there's no fee for service. So, if I'm doing an open aortic aneurysm and there's not a senior trainee around, because we struggle sometimes to get enough trainees to cover the service, then to have two consultants operating together with skill mix, and I might be better than them at certain things, and they're likely to be better than me at most other things. So, you can work together and you can learn from each other, and I think it makes it's much better for the patient. I think not just the technical side, but the decision making. And if you can do it in your healthcare system, if it's financially possible, then I would strongly recommend it. And I am at a stage of my career where I'm learning a lot more from other people than I.
Professor Hulin?
Oh yeah, I agree with both of the two other speakers that normally we have different skills within the group, and we can help each other. I think that's the best way to do it. I don't think that endovascular is going to become a subspecialty, a separate subspecialty, but if I'm pessimistic, I may think that perhaps open surgery could become a subspecialty, because we need to have training on relatively few hands so that everybody gets enough cases to be able to do it properly.
Professor Bradbury?
I would agree with that, and I would not be surprised if aortic surgery became a separate specialty in the UK, because the caseload is going down quite rapidly, and the patients are more and more complicated and more unfit. So I think you might have aortic surgeons and leg surgeons be subspecialization, but I think they'll do endo and open for aortic and open and endo for legs. Yeah.
Okay, just the last question from the audience from Oman. A colleague asked us, COVID-19 increases the chance of peripheral arterial disease. Any studies will be conducted? Professor Farber, USA.
Yeah, I don't think. Yeah, I don't think COVID increases the risk of PAD, but I think COVID does increase the risk of hypercoagulability. And there's a big effort that's being organized by the National Institutes of Health to ask questions about hypercoagulability in patients with COVID before admission, during admission, and upon discharge. A very, very big effort that's literally being organized as we speak about that.
Please, Professor Bradbury. In UK,
I agree. There's a lot of interest in hypercoagulability in the UK too, on the venous side as well as the arterial side. But what we've observed is people being more reluctant to come to hospital, although we've been there for them. Most services in hospital, and vascular is no exception, have noticed a reduced number of people coming to hospital because they're scared of coming to hospital. And so anecdotally, we observe people presenting late, whether that's with stroke or heart attack or legs. So we're trying very hard to encourage people to still come to the hospital if they present with a life or limb threatening condition, but it's been quite difficult.
Okay. In Denmark, Professor Holland?
Well, more or less the same. There's some interest research-wise in hypercoagulability. I think another reason why I think we've lost at least one leg recently in a patient with sepsis and hypotension because of COVID-19, and that's maybe another reason for that we get the impression that COVID-19 increases the risk of PAD. It's probably not the PAD that's increased.
Okay. Any comments or questions from the speakers? No. Okay, so I think it's time to close this webinar. It was very interesting, very exciting from my point of view. There are still about 50 attendees after 1 hour and a half. So I hope that the attendees enjoyed this webinar, this overview about open peripheral revascularization. So I thank again Lemaitre company for the support, and I thank again Tobias, and I ask Tobias to conclude this webinar with the final words from his point of view. Thank you, Tobias.
Yeah. Thank you to all presenters and you, Nicola, for the moderating portion here. I think this was a very interesting event. We got some nice questions. I think people were also very eager to get an update on these different trials and where are we heading to possibly. I think this was good discussions. I appreciate your attendance, your presentations, and your discussions. And I hope we can conduct some kind of similar event, maybe on some other hot topic in vascular surgery in the near future. Thank you very much, all attendees, also in the audience, and I wish you all a good day.
Thank you. Bye-bye. Thank you.
Thank you.
Bye-bye. Bye-bye. Thank you.